Hi, my name is Mrs. Campagna, and today we're going to go over fluid and electrolytes and acid-base imbalances. Okay, after we get done with the video, after we get done going over the slides, we're going to go over some practice questions with you guys. Okay, so let's get started. Okay, so first of all, we need to go over the homeostatic control system. So what is this exactly? Well, your body's always trying to maintain homeostasis, right? It's always trying to stay even keel. It's always trying to have checks and balances there that fix itself. When you're deficient in one area, you make up for it somewhere else. Or you pull, for example, if your blood's low in calcium, your body pulls it from the bones to try to make up for that. Okay, so we're always trying to maintain homeostasis. Something goes wrong, it sends a signal, and the signal gets picked up, and then something compensates. And that's how we maintain homeostasis. So in terms of fluid balance, since we're talking about fluid and electrolytes, there are some ways in the body, our body has hormones that help us maintain fluid balance. The first one is aldosterone. And aldosterone is released when we have a low sodium, okay? And the kidneys hold on to sodium. So if our body sees that our sodium is low, then our kidneys will hold on to sodium, okay? And then water follows sodium. Antidiuretic hormone, also called ADH or vasopressin. Okay, so what do we see about this that looks familiar? The word diuretic, right? So we know that when we give a diuretic, so we know with antidiuretic hormone that with diuretics, we give those to patients to get rid of fluid, right? So they're going to get rid of the fluid through their kidneys. So with an antidiuretic hormone, the body stimulates the kidneys to hold on to fluid, okay? So our body regulates our antidiuretic hormone to either hold on to fluid or not give as much of the antidiuretic hormone so that our kidneys actually let go of a little bit of fluid, okay? The next one we have is the natriuretic peptides. They're released by the heart muscle, okay? So when the heart muscle stretches, either by volume or by increased pressure, okay, then that sends a signal to the kidneys to let go of some water. So some of you may have heard of a lab called a brain natriuretic peptide, or a BNP. Okay, so the BNP we use a lot of times in congestive heart failure patients to see how much fluid overload they have going on. So the higher their BNP, the more stretch and volume they have going on in their heart muscle, which means they've got a lot of pressure backup or a lot of volume in there, and that can measure fluid volume overload, okay? So, but anyway, the natriuretic peptides send signals to the kidneys to help them get rid of some of that extra water. So those are just some ways that we have our body helps us get rid of or hold on to fluid to help regulate our fluid levels. So the next thing we have here is the renin-angiotensin-aldosterone system. So this system is very integral in helping us maintain homeostasis within our bloodstream, or it helps anyway, okay? So here we have a picture of a little kidney, and he is watching a monitor, okay? So he's monitoring the blood. So the kidneys monitor the blood for low blood volume, okay, because we don't want a low volume because then our blood pressure drops and we don't get our organs perfused. Low blood oxygen, because again our organs don't get perfused with the oxygen that they need. And then low blood sodium. Okay, so any of those happen, the little kidneys watching the monitor, if any of this stuff happens, then the kidneys release renin. And that in turn starts the renin-angiotensin-aldosterone system. So renin gets released from the kidney, and it joins angiotensinogen, which is then released from the liver. Okay, so these two together then make angiotensin 1. Okay, this circulates through the blood, and when it makes its way up to the lungs, in the lungs we have angiotensin converting enzyme that's released. Angiotensin converting enzyme, that may sound familiar, the ACE inhibitor, sound familiar? Okay, so we'll get to that in a minute. So the angiotensin converting enzyme then converts angiotensin 1 to angiotensin 2. Angiotensin 2 is the one that has all the effects on our body. Okay, so angiotensin 2 does a couple things. The first thing it does is it causes vasoconstriction throughout the body, but including the arterioles of the kidney. Okay, so when we have vasoconstriction in the arterioles of the kidney, we get a decreased urine output. So if our urine output is decreased, then that fluid that would be coming out in the urine is staying in the bloodstream, therefore raising fluid volume. We also have the adrenal gland, angiotensin 2 sends a signal to the adrenal gland to then release aldosterone. And we remember that aldosterone is the one that holds on to salt. Okay, and what follows salt? Water. Okay, so this again will increase our fluid volume. It'll also increase our sodium level and help get our oxygen perfused to our vital organs. Okay, so this system raises blood pressure. Okay, it raises blood pressure. So if you have, remember how we were talking about the ACE inhibitor? So if you have an ACE inhibitor, the ACE inhibitor actually prevents this section of the renin-angiotensin-aldosterone system from happening. Okay, so ACE converts angiotensin 1 to angiotensin 2, and then angiotensin 2 does all this down here. So if you put an ACE inhibitor right here, okay, then angiotensin 2 never happens, this never happens, and the aldosterone doesn't happen. So therefore, the blood pressure doesn't go up. Okay, so that's why an ACE inhibitor is used to control blood pressure. Okay, it's used to lower blood pressure because it prevents the vasoconstriction and prevents the holding on of salt and water. Okay, and here's a YouTube video down here to help explain the renin-angiotensin-aldosterone system a little further if you need it. The next thing we're going to talk about is the basics of hydration. Okay, so if you're dehydrated, your blood is concentrated. If you're overhydrated, your blood is dilute. Okay, so if your blood is normal, then you have fluid here and you have all your particles and electrolytes here. So you're about even. Okay, so you've got fluid here. And then you have your particles here, like red blood cells and electrolytes and things like that. Okay, so when you're dehydrated, okay, you look like this. You have fluid down here, but your particles are still up here. Okay, so if this is your fluid, and here's your particles. So what happens here in your blood is this, when you're dehydrated, this is why levels go up with dehydration, like hematocrit goes up, sodium goes up, your urine-specific gravity will go up because the more dehydrated you are, the more concentrated your urine's going to be because your kidneys are trying to hold on to any fluid it has going through it to try to keep your body's organs perfused. Okay, so you're not going to put out a lot of urine when you're dehydrated. So your urine-specific gravity will also go up because the more concentrated your urine is, the higher the specific gravity. When you're overhydrated, okay, well then you have a situation like this where you've got too much fluid, pardon my artistic work here, and you have this amount of particles. Okay, so the particles didn't change, but the fluid's changing. So when you have a lab tech reading your lab results, all they're really reading is the proportions, okay, the ratio. How much fluid to particles do we have going on here? So we see with dehydration, we've got way more particles than fluid. In overhydration, we have more fluid than particles. So it's going to look like our electrolytes, hematocrit, things like that are low because we are diluting them. Okay, so this is normal hydration. This is dehydration. Okay, so this is dehydration, and this is overhydration. Okay, so let's look back at this slide now and see if this helps make more sense to that. Okay, so this says, watch us go up with too little body fluid. Okay, so remember we said as you are dehydrated, your urine and your blood are more concentrated, meaning there's lower fluid, higher particles. So our urine specific gravity is going to go up, our hematocrit goes up, and our sodium goes up. Just some examples of things that are going to go up when we are hemoconcentrated or dehydrated. And then as you become more dilute, okay, when that fluid level rises in your bloodstream, then your sodium's going to drop, your hematocrit's going to drop, and your urine specific gravity is going to drop because the kidneys are going to start kicking out more fluid. So it says this here is using hemoglobin and hematocrit as a guide to hydration status. Okay, so here's another example like the drawing that I just did for you guys. As you are more diluted or overloaded with fluid, you have more fluid in this test tube than you do particles. And then here we've got normal, about half and half, and then here we have more particles and less fluid. So as you are more diluted, your hemoglobin will go down. And as you are more concentrated, your hemoglobin level goes up because your hemoglobin's part of these particles here, okay? I'm sorry, your hematocrit. Your hematocrit's what I'm talking about. So your hematocrit's part of your particles here. So it's going to go up when you're hemoconcentrated and down when you're diluted. Okay, so enough about that. Let's talk about dehydration. No water, no salt, or both. Yes, because water follows salt. Okay, so what are some causes of dehydration? Not taking in enough fluid. A lot of people forget that. They think about, they think about vomiting and diarrhea and NG suctioning and diaphoresis and fevers and sweating. And those are all correct, but the thing we have to remember is you can also become dehydrated just for not taking enough in, because we have that little thing called insensible water loss. So even when we're trying not to get rid of fluid, we still get rid of it whether we want to or not just by breathing, for example. So remember, anybody who's not taking in enough fluid as well. So you have those people, maybe they're just super nauseous and they can't take anything in because even just a sip makes them feel like they want to throw up even though they haven't thrown up anything. You have those people. You also have people, don't forget, and this is going to be more common even than that, is going to be your people on NPO status. So when you're working as a nurse in the hospital, that's one thing you have to remember is when somebody's NPO, usually, if they're going to be NPO for an extended period of time, we need to get them on some kind of IV fluids. Okay. Now here there's a little bit about diabetes insipidus. You guys don't have to worry about diabetes insipidus because it does cause excessive fluid loss, but that's more of a NUR245 thing. But this is just a visual representation of dehydration here. Okay, let's move on here. Here are some signs and symptoms of dehydration. Okay, so dry mouth is that's pretty Pretty easy to think of, don't have any fluid, you're going to get dry mouth, you're going to get thirsty, because if your bloodstream has a low amount of fluid, it's going to tell your brain, hey brain, I need some fluid in here, I'm thirsty, I need to replenish my fluid. Okay, we talked about the decreased urine output. You're not going to have as much perfusion going on because you have a low fluid volume, so you're going to get tired. Your skin's going to be dry, low perfusion again, so you're going to get a little bit of a headache there. Fever is usually just associated with dehydration, because of a lot of the things that cause dehydration also cause fever. No tears when crying. Okay, now what about these? Rapid heartbeat and rapid breathing. Why would these occur? Well, these happen because if you have a low fluid volume going through your heart, your brain tells your heart, beat faster to get what little fluid you have out to the vital organs quicker, okay? It also tells the lungs, breathe faster to oxygenate what little blood you have and fluid that you have, so that the heart can get it out to the rest of the body quicker. How do we fix it, right? Because we understand the signs and symptoms now, we understand the causes, but we forgot to talk about how to fix it. So how do we fix dehydration? Fluid, right? We give them fluid. If they're dehydrated, you give them fluid. You can either replace it orally or intravenously. The type of IV fluid is going to depend on the reason for the dehydration. Okay? We also have to monitor this patient for safety. Why is this patient at a safety risk? Well, if you're dehydrated, you're going to get dizzy, you're going to get lightheaded, and it's possible that you could fall. Okay? We also have to make sure we monitor their pulse rate and they don't get too super high, and we have to make sure their urine output doesn't drop too low. We want them to, what's the minimum that we want the kidneys to be working at? 30 mLs per hour. So we don't want those kidneys dropping that urine output below 30 mLs per hour, because then that's signifying that those kidneys are starting to shut down. So we have to make sure that we monitor that urine output and we don't get too low. Okay, now let's go back to overhydration. So what are some causes of too much fluid in the body? So let's start with the obvious ones. Okay, too much IV fluid. That's a big one, right? We are giving the patient fluids at 125, 150 cc's per hour, and the patient doesn't need that much anymore. They may have needed it at first, but then we've left it going on, and now the patient is able to take in things by mouth, and now they're getting in too much water, too much fluid. Along those lines, another common way to cause fluid volume excess in a patient is a blood transfusion. And a lot of that has to do with patients who have a poor cardiac history. If you give them too much, because every bag of blood doesn't just have the red cells and the hemoglobin and hematocrit and everything in it. It also has fluid in it, just like our blood does. So when you give that patient a bag of blood, that's 350 cc's of blood and fluid volume. So if you're giving a patient 2, 3, 4 units of blood, you're looking at anywhere from 700 to 1300 1400 cc's of fluid that you're giving this patient in a decreased amount of time. So we have to make sure we monitor those patients for fluid volume overload while we're giving a blood transfusion. That's why you always assess the patient before you start the blood transfusion. You're listening to their lungs, you're checking for edema, You're checking for JVD and things like that, along with vital signs, of course, because you're looking for a transfusion reaction as well. But then you also have to monitor for the fluid volume overload as well. And I guarantee you, you'll see fluid volume overload a lot more often than you're going to see a blood transfusion reaction. But you always have to check for both. Another thing that we have to worry about is too much water intake, although you don't see that a lot. Usually you don't see somebody with water toxicity. That one's not as common. What about the kidneys not working right? Remember, one of the big things that we know that the job of the kidneys is to regulate fluid, right? We just talked about the renin-angiotensin-aldosterone system, and that all takes place in or near the kidneys. So if the kidneys are failing and can't do their job anymore, they're not going to be able to let go of the fluid like they need to. Okay, so renal failure patients, when they go to get dialysis, yeah, they get the BUN and creatinine taken off. They get the potassium taken off because the kidneys excrete that as well. But they also get fluid pulled off because they're at risk for fluid volume overload. And another one at risk for fluid volume overload, CHF, congestive heart failure patients. Okay, so we know that congestive heart failure patients, they're fluid volume overload. When you think fluid volume overload, immediately you think congestive heart failure. But one thing you have to remember is the reason why. So the heart muscle can't pump as well as it usually would, okay? It's weak, it's tired, it's stretched out, it doesn't squeeze like it should. When this happens, you get a fluid backup into the lungs, or you get it into the venous side of the body, okay? But what also happens is it's not coming out the left side into the aorta and the rest of the body like it should, okay? And if we remember back to our little kidney guy here, so he's monitoring for low blood volume, right? And if the blood coming out of the left side of the heart is at a low volume because the heart's not pumping it out as efficiently as it should, well, then the kidneys say, I've got a low blood volume. I need to hold on to fluid, okay? And when it holds on to fluid, then we get into the fluid volume overload. And we have a wicked cycle going on because not only do the kidneys are holding on to fluid, but then you also have where the heart can't pump it correctly, so it just backs up, and then the kidneys hold on to more, and it backs up. So that's why we give patients like that diuretics. Okay, so when we talk about the signs and symptoms, we can have things like edema, okay? They're gonna they may not be real hungry, they may be nauseous because they're full of fluid, okay? Their blood pressure can go up because their blood pressure is affected by two things, guys, and write this down, this is important. It's affected by fluid volume and constriction of the blood vessels. Okay, those two things. Those are the two things that affect blood pressure. It all comes down to those two basic things. Blood pressure is affected by fluid volume and constriction of blood vessels. So in this case, overhydration, we're talking about fluid volume. Okay, so your blood pressure is going to go up because you've got excess volume. You're also going to see JVD. You're going to get changes in level of consciousness, so they could become confused and have headaches. Okay, and then you're going to get the pulmonary congestion because it's going to be too much fluid and it's going to leak out into the through the capillaries into the lungs. Okay, and then you're also going to have problems with hemodilution. Okay, and this is not on this slide, but remember back to our slide here. See here with the hemodilution, too much fluid, just a little bit of particles. So what happens here, this is fluid volume excess here. And this here is where your potassium, your sodium, your hemoglobin and hematocrit, everything's tucked down in this tiny little space down here, okay, when you're hemodiluted. So when a lab technician goes and looks at this, he's going to see that it looks like you have low sodium, low potassium, low magnesium, everything like that because you're hemodiluted, okay? And your body sees it that way as well. And you are having too much fluid and not enough of the potassium, sodium, and things like that. So then you have the electrolyte problems as well. So how do we fix fluid volume excess? All right, how do we fix fluid volume excess? We're going to put them on a fluid restriction, okay? We don't want them putting more fluid in their body if they've already got too much floating around in there, okay? We're also going to make sure we have them get weighed daily, because weights are the best way to monitor fluid volume in the body as far as too much, too little, have we lost some, have we gained some. Weight is one of the most accurate ways to do that. You have them weigh themselves, or you weigh them if they're in the hospital at the same time every day with the same amount of clothing on. And by doing this, I believe it's 1 liter of fluid weighs around like 2.2 pounds or something. It's similar, something like that. So if a patient puts on weight within a matter of a day or two, we know that that's fluid, okay? And then a patient loses weight, we know that they've lost fluid, okay? Because fat weight takes longer to put on. Fluid weight, it gets put on very quickly, and that's why we measure the weight every single day. We also measure intake and output. How much is this person bringing in versus how much is those kidneys putting out? We want to make sure we match up there. Okay, so we've got the monitor, and then the fluid restriction. The nurses here are also checking his lungs, and they're checking his cardiovascular status, okay? But how else do we treat fluid volume overload? We get rid of the fluid, right? So we're going to give them diuretics to get rid of the fluid. We can also put them on a low salt diet, because remember, water follows salt. So if you have less salt floating around in your bloodstream, you're going to have less water. Or if you have, we don't want excess salt, I should say. You don't want excess salt in your bloodstream from taking too much in via food, because then you'll retain water. So the reason I put this slide in here is just this is another way to evaluate hydration status, okay? So we've got some buns running here, right? The run of the bun. So, but it's actually BUN, okay? And what the BUN does is it measures, one of the things it measures is dehydration and overhydration. So if your BUN is high, you're dehydrated. Just like if your hematocrit is high, you're dehydrated. And then if your BUN is low, you're overhydrated. Okay, let's go over IV fluids. And these are good to know because there's usually a test question somewhere about what IV fluid is appropriate. Okay, so first of all, let's take a look at the top guys. These top guys are your isotonics, okay? So their concentration of particles versus fluid is going to be similar to our blood, okay? So if you infuse somebody with an isotonic solution, you're not really gonna affect the way there's any kind of fluid shift, okay? You're just gonna add fluid to them. So the normal salines used to expand volume, dilute medications, and keep veins open. And then you have your lactated ringers. You get that if you need someone to have more fluid on board. So the next one is, down here we've got hypotonic and hypertonic, okay? So your hypertonics are your D5 normal and your D5.5 normal. Okay, you've got those extra particles in here that makes this solution higher in particles than in fluid. Okay, so what we get when this happens, when you get a solution that's higher in particles than in fluid, here's what happens. So first we'll take the bloodstream. This is the bloodstream here. Okay, and then we'll take a little cell, and the cell's over here. Sorry about that. There's our little cell. Okay, so what happens here is if you have a hypertonic solution, that means that there are more particles out here, and higher particles concentration to fluid ratio. Okay, so hypertonic solution means your particles are up here and your fluid's here. Okay, so you have more particles and less fluid. That's a hypertonic solution. So if you put this type of solution, here's your particles. If you put this type of solution into the bloodstream, then you've got lots of particles and less fluid. So your cell sees that and it says, hey, I've got water in here. I need to kick some of this water out and put it into the bloodstream so that we even everything out. Because your body always likes to have everything evened out, that whole osmosis thing. So as this hypertonic solution flows past your cells kick out water in order to make the concentration of particles the same within the cell as it is outside of the cell in the blood vessels. Okay, so a hypertonic solution is going to raise fluid volume because you're going to pull fluid out of the cells and you're going to put it into the bloodstream because the body's trying to even out the level of the concentration. Okay? If you have a hypotonic solution, you have the opposite effect. A hypotonic solution looks like this, where you've got a low number of particles and a high amount of fluid. So in that case, what's going to happen is you're going to, let me just draw a new blood vessel over here so we don't get confused. So here's a blood vessel, and here's a cell. Okay, so in this case, we have a lower number of particles, okay, and we have higher volume of fluid. So what happens in this case is some of the fluid from the bloodstream goes into the cell to even both sides out, okay, and that's going to decrease fluid volume a little bit. Okay. The problem with the hypotonic solutions though, is especially like the D5W. So the D5W, the dextrose gets metabolized as soon as you put it into the body. So it becomes hypotonic. Okay, so as we were talking about the hypertonic and the hypotonic, with the hypertonic solutions, you got to be careful. It says here that it's used for sodium and volume replacement. But if we go back to this here, if we're pulling fluid out of the cell into the bloodstream, we're increasing fluid volume, which puts the patient at risk for what? Fluid volume overload, okay? If we're pulling fluid out of the cell and putting it into the bloodstream, we are raising fluid volume. So we've got to monitor this patient's blood pressure. We have to monitor for edema and fluid volume overload. In the same respect, the hypotonic solutions, okay, you're pulling fluid out of the bloodstream and putting it into the cell. If you're pulling fluid out of the bloodstream, putting it into the cell, we have to be careful in giving hypotonic solutions to patients like brain injury patients, because you're putting fluid in the cell can start to swell, okay? And swollen cells increases intracranial pressure. It decreases your ability for those cells to work properly if they get too much fluid in them. Okay, they get too swollen. So we have to be very careful when we're giving this fluid to people with brain injuries, okay? Because we're going to swell up the cells. Okay, so hypertonic solutions, you got to watch for fluid volume overload. Hypotonic solutions, you got to watch for too much cell swelling. All right, so now let's get into these electrolytes. Okay, the first electrolyte we have is sodium. Here's some things that the sodium is responsible for. And you'll notice throughout all of these electrolytes, a lot of them are responsible for similar things, okay? So sodium, fluid balance. Salt follows water, right? Sodium's also responsible for helping regulate blood pressure, and we learned that with the aldosterone, right? Kidneys hold on to the salt in the water, and that helps regulate blood pressure, because blood pressure is affected by what two things? Fluid volume and constriction of blood vessels. So the sodium works with the fluid volume part of the blood pressure. Then we have muscle function, okay, sodium potassium pump, sound familiar? And nerve function. So the sodium works with the membrane excitability. Actually, all the electrolytes do. What we have to remember with sodium is if the sodium's low, the excitability goes down, okay? And then if the sodium's high, the excitability goes up. And we'll talk more about that in a second. Okay, so let's talk about hyponatremia. Low sodium. The biggest thing to remember about low sodium are you're going to have neurological symptoms, okay? Could be tired, headache, a little confused, okay? Or it could be as bad as seizures and coma, okay? The reason for that is you decrease the membrane excitability, okay, of the neurons. So you're going to have a lot of slowing down of things, okay? So sodium is 135 to 145. Usually a drop in sodium is caused by hemodilution. Remember we talked about that, higher fluid volume, lower particles, or you just are losing too much sodium, okay? How can you do that? Diuretics, vomiting, NG suctioning. Just for the record, I like to equate NG suctioning and vomiting are pretty much the same thing. You have to monitor for the same things. You really have to worry about the same complications, because vomiting is the body's doing it itself. GI suctioning is basically we're doing it for them, but it's still you're losing all your gastric contents. Okay, diarrhea, you can lose sodium that way. Not taking in enough salt, although I don't really see that that's a problem very much here in the United States. Everything is full of salt. Then we have something called mannitol. Now, mannitol is where you pull fluid out of the cells into the bloodstream, and that can lead to hemodilution. Okay, and that'll drop your sodium because your blood's got too much fluid going in it. All right. So just remember also that hyponatremia can cause an increased intracranial pressure, okay? And let me explain why. Okay, let me get rid of this here. Let me start a new one here. Okay, so when you have a cell, okay, and this is kind of like having a hypotonic solution that we talked about before, but we'll talk about it when it comes to low sodium. Here's a bloodstream, here's a cell. So if you have, you know, low sodium out here, you should have more, right? Okay, what happens is the body then says, I need to put some fluid into here because I have too much fluid in the bloodstream. So some of this fluid's got to go into the cell to equal out the fluid levels because there's too much fluid over here. That's what the body's thinking because it sees a low sodium, so it thinks there's too much fluid. So it shifts some of the fluid into the cell. What happens then, though, is this cell gets bigger. Remember we talked about when you give somebody a hypotonic solution that the cell can swell? The same thing can happen in hyponatremia. The body actually sees the blood as being hypotonic with hyponatremia, and it actually pulls some fluid into the cell and can cause cell swelling. So hyponatremia can cause intracranial pressure to increase because the cell gets swollen from pulling extra fluid out of the bloodstream. So how do we fix hyponatremia? Well, if it's not too severe, if it's like, you know, sodium of like 130, we can try increasing the PO salt intake, okay? Feeding them lots of Campbell's soup. Now, you got to worry about fluid with that one as well. You can also give them small amounts of the hypertonic IV solution like 3% normal saline. Or you can give them medications that are going to decrease the fluid without decreasing the salt to try to even that level out again so that the ratio of fluid to salt in the bloodstream is back to normal. So now let's talk about hypernatremia. So hypernatremia is the opposite of hypo. So your symptoms with hypernatremia, remember we said that when you have low sodium, the tissues are less excitable. When you have high sodium, your tissues are more excitable, okay? You can have things like muscle twitching. So let's look at this little slide here for hypernatremia. So it says, hello brain, this is the hypothalamus. Say we've got a problem. Sodium and osmolarity are up. My guy here is really thirsty. Okay, so why is this guy thirsty? He's thirsty because his concentration of sodium versus water is high. His sodium level is high and his fluid volume is low. That's how it looks to the body. Okay, so the brain says, drink, 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 drink to bring the fluid level back up to make it even with the sodium level. Okay? Well, the brain says, thank you, I'll tell the pituitary. The pituitary says, I'm going to release some anti-diuretic hormone. So what happens is the pituitary sees a high sodium level and it says, let me tell the kidneys to hold on to some water, right? Here's the kidneys. Let me tell the kidneys to hold on to some water to balance out that fluid and salt ratio, okay? So if you have high salt and a little bit of fluid, okay, hypernatremia, then if you hold on to this, if you send this antidiuretic hormone that tells the kidneys to hold on to the water, then the kidneys will hold on to the water and then you will have salt and water, same level, okay? So your body's trying to regulate itself. This is that homeostasis control system. Your body's trying to fix itself. Okay, so if you have hypernatremia, you can be thirsty, your mucous membranes can be dry, okay, you can be restless, you can have muscle twitching. So how do we fix this? There's a couple ways to fix this. You can give IV fluids. like isotonic solutions. Isotonic solutions are going to bring the fluid level up in your body so that it evens out with the sodium level, okay? So that everything goes back to a good ratio, okay? You can also use diuretics and get rid of sodium that way, or you can put them on a sodium restriction. One thing you have to remember when you're trying to regulate sodium in the body is that water and sodium tend to like to go together. So you have to, it's a delicate balance that you have to do, and you have to be very careful of when you're correcting hypo or hypernatremia. You've got to monitor your patients for fluid volume overload or fluid loss, okay? What kind of foods have sodium in them? Well, pretty much everything that's processed. But here's an example. Things you have to remember are prepared meals, okay? Your frozen dinners. Even like, see here, see this here? Healthy choice. Even healthy choice ain't so healthy, okay? Lean cuisine may be lean, but you're going to die from fluid volume overload by eating it, right? So anything that's processed, prepared, usually has a lot of sodium in it, a lot of them as a preservative. Soups have lots of sodium in them as a preservative. Canned goods in general have them as a preservative, okay? So just anything like that. And then you have your preserved meats and prepared meats, like all your lunch meats, sausages, ham, bacon, all that stuff's got tons of salt in it. Okay, let's go on to potassium. Potassium is the second electrolyte in the body that it's very similar in the way that what it does in the body. So when you think sodium, you think neuro. When you think potassium, most people think cardiac, which is correct. The other thing you have to remember about potassium is potassium works with muscle contraction as well. So does sodium, but potassium even more so. Smooth muscle, cardiac muscle, that's why it affects cardiac. And it also affects other skeletal muscles in your body. One being the diaphragm, okay? So you have to be careful with that. Sometimes if you have somebody that has a low potassium, their breathing can become shallow because their diaphragm is not expanding like it should. Hypokalemia, low potassium. So what causes a low potassium? Well, we've got two there for alkalosis, right? Anytime you have an alkalosis or a low acid in the body, you have a low potassium. Same thing goes with an acidosis. If you have an acidosis or a high acid in the body, you have a high potassium. And I'll explain that in just a second. Okay? Again, with the NG suctioning and the vomiting and diarrhea, you lose your electrolytes through your GI tract. Okay? So let's explain this whole alkalosis, acidosis, potassium relationship. All right, let's clear this out here. Okay. Okay, when you have acidosis, okay, there's too much hydrogen floating around in your blood, okay? Hydrogen is acid, okay? It's one of the acids in your body. You have too much of it floating around in your blood. So remember that the body's always trying to maintain homeostasis and even things out. So what then happens is the body actually tries to pull some of that hydrogen into the cell. When it pulls the hydrogen into the cell, the potassium, boop, gets kicked out. Okay? So the hydrogen goes in to try to even things out, but when it goes in, there's not enough room and it kicks out some of the potassium. So what happens then, your potassium level in your bloodstream goes up. Therefore, acidosis, high level of acid, equals high potassium. Okay? So, acidosis equals high potassium. Alkalosis is the opposite effect. When you are alkalotic, you don't have a lot of acid floating around in your body. You have not enough acid, right? So when that happens, the body says, I need to kick out some of this acid and put it in the bloodstream to even things out, right? So it kicks out the acid and puts it in the bloodstream. Well, then the potassium says, hey, I want that parking spot. And so it goes into the cell to take the spot that the hydrogen was holding. So then we lose our potassium in our bloodstream because it wants to go back into the cell. So with alkalosis, the potassium goes back into the cells to take the spots that the hydrogen are leaving, and we have a low potassium in the blood. Okay, so that's the relationship between potassium and acid and base. So that then explains why metabolic or respiratory alkalosis would then lead to a hypokalemia, okay? Because the potassium goes into the cell to try to take the place that the hydrogen left when it went back out to the bloodstream to try to even things out. All right, so down here, we're looking for signs and symptoms. You're going to watch for skeletal muscle weakness in the arms and legs progressing to the diaphragm. Okay, that can cause respiratory arrest. And then you can also cause things like constipation and things like that because it works on the smooth muscle as well as the skeletal muscle. And then it also works on the cardiac muscle, so you've got some EKG changes as well. So, how do we fix hypopotassemia or hypokalemia? We replace with PO potassium or IV potassium. Okay, next one is hyperkalemia, high potassium. Okay, high potassium is, here are some signs and symptoms of the high potassium. You have muscle twitches, because remember, the low potassium slowed everything down, so the high potassium is going to raise things up. It's going to cause cramping. It can make you irritable and anxious. It's going to drop your blood pressure. It's going to cause EKG changes. Okay, it's going to cause overexcitability on the EKG, and you can run into things like VTAC and things like that. Arrhythmias, we talked about that. Abdominal cramping and diarrhea. So the hypopotassium, the low potassium causes the constipation and the paralytic ileus. The high potassium does the opposite, causes cramping and diarrhea. So how do we fix high potassium? We get rid of the potassium. Now how do we do that? There's a couple ways we can do it. One way is by Kayexalate. Now, Kayexalate is a drug. It's spelled Kayexelate. Kayexalate. I think that's the brand name, though. You guys will have to look up the generic. That drug is a drug that pulls the potassium out through the GI tract and makes you poop it out. Okay, so if you give Kayexalate, you got to be getting rid of your potassium. Another thing you can do is you can give insulin and IV dextrose. IV insulin and IV dextrose. And you're probably thinking, well, why does that? I don't understand what happens with that. How does that have to do with anything? Let me explain. Okay, so how does this insulin dextrose thing help the potassium? Okay, so first we're going to, again, draw our little cell and our bloodstream like we always do. Okay, so let me make my line a little darker here so you can see it. Okay, so here's our cell. Here's our bloodstream. okay? And I'm going to draw a picture that you're going to think is funny. I'm going to try my best. I'm not a good artist. Okay. This is called the insulin train, okay? Inside the insulin train, we have glucose and potassium. Potassium likes to follow glucose, okay? It follows glucose into the cell. How does that help us with insulin? Insulin helps the glucose get into the cell. So if you have glucose out here and you have potassium out here, okay, and you have glucose, potassium. When you introduce insulin here, okay, the insulin train comes, okay, we're going to put insulin in here. Insulin then takes glucose and takes it into the cell. And what follows it? Potassium. Okay, so you have glucose going into the cell because insulin's ushering it in there and potassium follows. What does that do? It lowers our potassium level in the bloodstream. Yay, our potassium is fixed, right? But what else did we lower? We lowered glucose, right? So now we're made our patient hypoglycemic. How do we fix that? We give them 50% dextrose IV to replenish all the sugar we just put into the cells. Because this hyperkalemia can happen to patients who aren't diabetic. So you have a normal sugar level and you give that insulin to usher that glucose into the cell, not because you need to get rid of the glucose, but because the potassium will follow it. Okay, so we get the glucose into the cell, the potassium follows, but we've dropped the potassium, which is good, but we've dropped the glucose as well in a person who does not have a glycemic problem, okay? So this person is not a diabetic. We just needed to get rid of the potassium, and the only way to do that quickly was to get the glucose in the cell so the potassium would follow. So now we have a low glucose and a normal potassium, but we've got to replenish that sugar. So we give them IV sugar to put that sugar back in the bloodstream before the patient becomes hypoglycemic and starts showing symptoms. Okay, so those are the ways we treat hyperkalemia. Next thing we have is the foods high in potassium. And those are like your greens, your potatoes, your white fleshies, your citruses. With chloride, we're just going to say chloride and sodium are in a relationship together. And one goes low, the other one goes low. One goes high, the other one goes high. Let's talk about calcium. What does calcium do? We all know calcium works on the bones and teeth, right? Also has a big thing to do with muscle contraction, nerve function, and blood clotting. One thing we have to remember about calcium is as calcium gets low, it actually allows the sodium to kind of get higher and increase membrane excitability, okay? So the calcium kind of works with the sodium. So if the calcium's too low, then that sodium can get in there and cause an excitability. So if we have excitability, what are some things that some symptoms of hypocalcemia? Okay, so if you've got a low calcium, you're going to get things like convulsions, arrhythmias, tetany, spasms, and stridor. Now, what do all these have in common? These are all having to do with muscle contraction, right? So another couple hallmark symptoms of hypocalcemia are the Chov-Stecks and the Trousseaus, which I don't have a slide for, but we know that the Chov-Steck is the one where you touch the face and the patient's cheek kind of twitches, and then the other one is the bending of the arm, the trousseau. Okay, so how do we fix hypocalcemia? We are going to give a calcium replacement medication. We can increase the PO calcium intake. We have to make sure we're assessing their safety because they can have muscle issues with this, obviously, like we just talked about. Another thing we have to remember is that the body's always trying to maintain homeostasis and even out our levels. So I think I may have discussed this earlier, but when you have a low calcium, if your calcium remains chronically low, your body will pull your calcium from your bones in order to regulate your blood level of calcium. So if your blood level of calcium is low, it's going to pull from the bones to regulate that. But then what happens to your bones? Osteoporosis. Now this happens with a chronic hypocalcemia. This is why a lot of older patients are on calcium and vitamin D supplements to prevent the chronic hypocalcemia and to ensure that we're getting enough calcium in our body so that our bones are not depleted. Now what about hypercalcemia? Too much calcium. Okay, so if the hypocalcemia means everything's getting excitable, then the hypercalcemia is everything slowing down. Now if you notice, the calcium is the opposite of the sodium and potassium. Remember, low sodium and potassium meant everything was slowing down. High sodium and potassium meant everything was more excitable. Now with the hypercalcemia, and you'll see the same thing with the magnesium, if you have a low mag and a low calcium, everything speeds up. And if you have a high mag, high calcium, everything slows down. So mag and calcium are the opposite of sodium and potassium as far as the membrane excitability. Okay? So too much calcium, big thing you have to worry about this is you can have heart problems with too much calcium. It can slow everything down and actually create things like heart block, bradycardia, and things like that. So how do you treat high calcium? So there's meds you can give to lower it. You can increase fluid volume, which will then even the levels out by diluting. You can also give diuretics to lose calcium, except for thiazide. You don't want to give thiazide diuretics. And then you can also give calcium binders. Here's some high calcium foods. See a lot of greens in there, huh? Lots of greens for the calcium. Calcium-phosphorus relationship, remember that they have an opposite relationship. When the calcium goes up, phos goes down. Phos goes up, calcium goes down. Foods high in phosphorus: meat, fast food, canned fish, cola. Okay, cola is high in phosphorus. Let's talk about mag. Muscle contraction, carbohydrate metabolism, energy, and blood coagulation. So what are some things that magnesium does? I'm sorry, let's first of all, let's talk about causes of low magnesium. Okay, so if you have malnutrition or malabsorption and you can't get that magnesium in, diarrhea can drop your mag. Alcohol abuse can drop your mag. Diuretics drop your mag. And then you also have things like Crohn's disease. Now the Crohn's disease, you get the malabsorption. Okay, you can't absorb your nutrients like you would in a normal intestinal tract, because Crohn's disease is where you have it's an autoimmune disease of the intestines, most of the small intestine. Crohn's disease deals with the malabsorption. You can't absorb your nutrients through your GI tract as efficiently, and those people are often very skinny. And then also you can get severe diarrhea with Crohn's. So you kind of get a 1-2 punch there with losing your magnesium with Crohn's disease. Another one here we see is the metabolic acidosis with dialysis or renal failure. And this is because with dialysis and renal failure, in the metabolic acidosis, you actually can cause the kidney to lose the magnesium. Okay, so when you have a low mag, you increase membrane excitability. Remember, it's the opposite of the sodium potassium, same as calcium. You increase membrane excitability. Okay. One thing that's different about mag, though, is you actually decrease GI motility with a low mag. And how do you fix this? You're going to replace with IV magnesium usually. Okay, and then we have a high mag here, remember? So if everything was overexcitable with the low mag, everything's slower with the high mag. Okay, nausea, vomiting, muscle weakness, hypotension, bradycardia, respiratory depression, decreased muscle contraction. Okay. How do you fix it? You're going to give IV fluids to dilute, usually, except maybe in renal failure. You can also give diuretics to get rid of the mag. Here's some magnesium-rich foods. Look at those almonds. No wonder they call almonds a superfood. They're like in every single category. All right, now let's talk about acid and base. What are the different types of acids in your body? You have hydrogen ions. We talked about that a little bit earlier. Ketoacids. What does that sound familiar for? Diabetes. Ketoacidosis. And then we have carbon dioxide, which is a carbonic acid. So when you see carbon dioxide, you think acid. Carbon dioxide equals acid. And then we have lactic acid. Okay, so how do these build up in our body? So the hydrogen ions are they're there from different chemicals breaking down. Then you have the ketoacids. The ketoacids are from the fatty acids breaking down. When your body cannot get the glucose that it needs, it starts breaking down muscles and fat to get its energy. Okay, so when it breaks down the fatty acids, when it breaks down fat, a fatty acid gets left. That fatty acid turns into a ketone body, which is an acid or a ketoacid. Get too many of those in your body, you get ketoacidosis. Carbon dioxide is a carbonic acid. We breathe that out. And then we have lactic acid. So lactic acid is something that builds up when your body tries to do its Krebs cycle and create its energy without oxygen. So if you have somebody in a hypoxemic state, their lactic acid can build up because their cells will continue to try to make energy, but they will try to do it without using oxygen. And when they do that, a byproduct is lactic acid. Okay, so if you have trying to create energy without the use of oxygen, because you're in a hypoxemic state, your lactic acid will build up. Okay, so you become acidotic. What's the base in our body? Bicarb. Where is most of it regulated? Kidneys. Okay, so let's move on. Respiratory acidosis. So the thing you got to remember about respiratory acidosis is you're not getting rid of your CO2 in your lungs. Okay? Why could that be? You're either not breathing deep enough, or you're not breathing fast enough, or you have some kind of condition that is not allowing you to get rid of the CO2. Okay? So what are some of the reasons? Over-sedation. Okay? If you're sedated too much, you're not going to breathe deep enough or fast enough to get rid of that CO2. Brainstem trauma. We know that the breathing is controlled in the brainstem. If the brainstem's messed up, the breathing's going to be messed up. If your breathing's messed up, you're probably going to retain CO2. okay? Immobility, you're not breathing deep as you should, okay? Respiratory muscle paralysis, again, not breathing deep enough or fast enough. Okay, and then you have things like pneumonia, pulmonary edema, emphysema, bronchitis. Those are all conditions that are going to limit the amount of CO2 you can get rid of because things are in the way. Okay? So these are people that you're going to see, the respiratory distress patients, the sedated patients, the patients who are coding. Okay, these guys are all going to go into respiratory acidosis. Not getting rid of the CO2 through your lungs. Now let's look at respiratory alkalosis. Okay, so this is the opposite. They're getting rid of too much CO2. So too much CO2 is going out because they're breathing too fast. Okay, hyperventilation. So that's what's happening with the alkalosis. So these patients are going to be your anxious patients, the panic attack patients. Why do you think we have patients who are or people in general, you see it on the movies and TV, they're having a panic attack. They breathe into a paper bag. Why do we do that? Because we want them to rebreathe some of the CO2 that they're breathing out. So they breathe in the paper bag and they inhale in the paper bag and they're inhaling some of that CO2 back into their lungs to try to replace too much that they're losing. Okay, so when we have somebody who's having an anxiety attack, we give them a paper bag, that's to rebreathe that CO2 because they're breathing too much of it off. Okay, another way you can get alkalosis is mechanical ventilation. Now you're wondering, well, why would that be? We're having a machine breathing for them. They should be doing it perfectly. Yes, but remember, your brain is constantly monitoring, your whole body is constantly monitoring the acid and base level and your pH level, okay? And it tries to regulate it out, okay? And it tries to keep your pH between 7.35 and 7.45. And if you're getting a little too high, little too low, your pH is getting too low and you're getting acidotic, your brain will tell your lungs to breathe a little faster to get rid of some of that CO2 to level you back out. And it's constantly doing that, okay? So what happens with the mechanical ventilator is that vent cannot monitor your lab values the way your brain can and your body, okay? And your brain and your body are constantly doing that. Where we only draw labs on a patient usually maybe every 6 hours or at the most, maybe more often than that, but it's not a constant thing. So what happens is the vent will only breathe as fast as the doctor programs it to. It can't measure whether or not it's making you acidotic or alkalotic. So it's just going to breathe as fast as the doctor told it to. So we may program that ventilator to breathe too fast for that patient, and we won't know that we're putting them into an alkalosis until we check their ABG. Okay, so mechanical ventilation can cause alkalosis by breathing too fast for the patient. And then we can also have a patient that's hyperventilating because of anxiety. Metabolic acidosis. Okay, so there's lots of things that can cause the metabolic. The respiratory is respiratory, right? Metabolic, there's lots of other things that can cause metabolic acidosis. So let's look at the possible causes down here. We have your keto acids. Remember, we talked about that with the diabetes. So if your body can't use the sugar because the insulin's not putting it in the cells, your body's going to break down fat and muscle to try to make energy. Okay, so to get its sugar. So what it does is when it breaks down that fat, you get the fatty acid that turns into a ketone body and you get keto acids. Okay, another thing is shock. So what does shock have to do with metabolic acidosis? Remember what I told you about lactic acid and hypoxemia. Okay, when your body is in a hypoxemic state, as in shock, remember with shock you usually have a drop in blood pressure. If you have a drop in blood pressure, you have decreased oxygen perfusion to your body's cells. If your cells are not getting the oxygen they need, they will start making energy without the use of oxygen. And when it does that, byproduct is lactic acid, okay? So metabolic acidosis from shock is caused by lactic acidosis. Then you have severe diarrhea, okay? So what happens with diarrhea? You probably think, oh, well, stomach acid, you're losing it. Actually, no, that's with vomiting. With diarrhea, you lose bicarb through your stool, okay? So you're pooping out the bicarb. And then remember that I said that bicarb, its main regulatory organ are the kidneys, right? So if your kidneys aren't working, you're not regulating your bicarb, and that can lead to acidosis. And then we have metabolic alkalosis. Okay, so this is things like the vomiting and the diuretics and the NG suctioning, things that are making you lose your acid, okay? Another thing is if you see this little guy down here, overdose of bicarb with CPR. So remember how I said somebody who is in cannot breathe off their CO2 is going to go into respiratory acidosis. So if you have somebody who is coding, they're not breathing, so they are going to hold on to that CO2 and they're going to go into respiratory acidosis. These patients also, when they're coding, are going into lactic acidosis because their organs are not getting the oxygen and the cells are trying to do their Krebs cycle to create energy without using oxygen, so they create the lactic acid. Okay, so you've got a double whammy of acid going on in a CPR situation, in a code situation. So one of the drugs that we give when we're coding someone is bicarb. Okay, we give it IV. But sometimes we can give them too much and then we tip the scale in the other direction and make them alkalotic. So you got to be careful with that as well. And then the last slide here is just causes of acid-base imbalances. And this is just another little visual to help you guys out. Okay, so that's the end of the slides. I'm going to take a couple minutes now, and I want you guys to go over the practice questions and review the practice questions, and then I will go over the practice questions with you guys. Okay, let's go over these practice questions. The first question is, number 1, a nurse teaches patients at a community center about the risks for dehydration. Which client is at greatest risk for dehydration? Okay, so let's look this over. The first one we have is a 36-year-old who is prescribed long-term steroid therapy. What do we know about steroids? That we know that they retain fluid. Okay, usually people on steroids get swollen, right? So they're really not going to have a dehydration issue. We have a 55-year-old receiving hypertonic IV fluids. Okay, so remember we learned about hypertonic. Okay, so the concentration of particles per fluid is higher in the bloodstream when you give hypertonic solution. So what's that going to do? It's going to pull fluid out of the cell into the bloodstream. That's going to raise your fluid level. So they are not at risk for dehydration. Then we have a 76-year-old who is cognitively impaired. Okay, so what do we worry about with patients who are cognitively impaired? We worry about maybe getting sick and not telling anyone, or not taking enough to eat or drink. Sometimes when people get old, they forget to eat if they have dementia and things like that. Okay, and then we have an 83-year-old with congestive heart failure, and we know I talked about that earlier. CHF causes you to retain water. So again, the only answer here that doesn't have you increase your fluid level is going to be the cognitively impaired gentleman. Okay, so the 70s, or it might be a lady, 76-year-old who's cognitively impaired. Number 2, a nurse caring for a client who exhibits dehydration-induced confusion. Which intervention should the nurse implement first? Okay, so we hear, what should we do first? Now remember, when you hear what is the nurse's priority or what should the nurse do first, you always remember your ABC safety, okay? What's the most important thing for this patient? So if you have confusion and they're dehydrated. Why is this happening? This is happening because they are not getting their oxygenated blood perfused to their brain, okay? Because they have a low fluid volume. But what's the first thing you can do? Okay, let's see. We're going to measure INO. Okay, that's really an assessment. That's not really, I mean, it is an intervention, but is that part of ABC safety? Not directly. Oxygen by mask or nasal cannula. That's B, that's breathing, right? Okay. Increase IV flow rate to 250 an hour. That's C, that's circulation, okay, out of your ABCs. And then you have place the client in high Fowler's position. Well, I guess that could help with breathing and circulation as well. But which one out of these? We said we've got B, C, and D. All three of those work with breathing and circulation, right? So out of those three, which one is the most, the quickest and the most direct? Okay, because it says what should the nurse do first? The quickest and most direct is going to be applying the oxygen. The reason for that being is you can place a client in high Fowler's, but it's probably not going to help them, especially if we're having decreased perfusion to the brain. Because if you have dehydration, you're probably going to have a low blood pressure. If you raise the patient's head of the bed to a high Fowler's position, you're then having gravity help pull that blood down out of the brain, okay? And if you have a dehydration situation with a lower blood pressure, you want to lower their bed just a little bit. Because remember, the problem with them is not that they can't breathe, it's that the blood's not getting as efficiently to the brain because there's a low volume, okay? So we want to give them oxygen first, because even though you think IV fluids, because you want to get that volume up, airway, breathing, circulation, so the B helps with oxygenating that little bit of fluid that they have to get it to the brain. So the next question is, after teaching a client who is being treated for dehydration, a nurse assesses the client's understanding. Which statement indicates the client correctly understood the teaching? Okay, so anytime you have a teaching question that says correctly understood or needs further teaching, okay, we're going to treat these like the answers like true false. So if the question asks which shows that the patient correctly understood, then we know we're going to pick the answer that is 100% true. And the reason I say 100% true is if any part of that statement is false, then the answer is incorrect. Okay, so make sure that you pick the statement that is 100% true. You may have one that's partly true, but that's not the correct answer because not all of it is true, okay? And the same goes for if you have a question that asks, which of the following shows that the patient needs further teaching, then you would pick the answer that is false, okay? So let's look at this one. This one says correctly understood teaching. Okay, so which of these teachings about dehydration is correct, 100%? Okay, the first one, I must drink a quart of water or other liquid each day. You probably want to drink more than that if you're at risk for if you're being treated for dehydration. Okay, I must weigh myself each morning before I eat or drink. Do you remember what I told you about daily weighing when it comes to fluid balance? Weighing yourself or weighing the client is the best way to tell of an acute fluid gain or loss, remember? So having the patient weigh himself or herself every day is probably a good way to monitor the dehydration level. Using a salt substitute when making and eating my meals, the third one there. A salt substitute, okay, if you have dehydration, that means you have a low fluid volume. If you're not getting any salt in by mouth, then you're going to have a lower salt level in your body, which means you're going to have a lower fluid level. Remember when we have patients who have fluid volume overload, we always tell them salt-restricted diet, right? Because we don't want them to bring any more salt on board because then we bring fluid on board. So if you have somebody who's dehydrated and you want them to have fluid on board, you tell them to eat the salt so that the fluid comes on board with the salt. Okay, so using a salt substitute is not what you want to tell a dehydrated patient. And then not drinking liquids after 6 so you don't have to get up at night. That is that's not a true statement either, because you still want them to have fluids in the evening. If they stop at 6 o'clock, they're going to get dehydrated, especially if they're already dehydrated. So the answer to that is weighing yourself, okay? Number 4, a nurse assesses a client who is prescribed a medication that inhibits angiotensin 1 to converting to angiotensin 2. Remember we talked about that, the ACE inhibitors. For which expected therapeutic effect should the nurse assess? So basically, one thing I like to tell my students is, when you're getting a test question, before you even look at the answers, figure out what the heck the question's asking you, okay? What is this question asking you? This question's asking, what do ACE inhibitors do? That's what this question's asking you. In a roundabout, wordy way, it's asking you, what do ACE inhibitors do for you? Okay? So what do ACE inhibitors do? Remember we said that it prevents angiotensin 1 to convert into angiotensin 2. And what does angiotensin 2 do? Angiotensin 2, up here, let's go back up to the very beginning. Angiotensin 2 vasoconstricts and causes you to retain salt and water, which raises blood pressure. So if you block that, you're going to lower blood pressure. So the answer would be dropping the blood pressure. Let's look at the other answers just to make sure we know why they're false. Okay, a daily weight increase. Okay, so if you're going to give an ACE inhibitor, you're going to inhibit the water retention. So you're not going to have a weight increase. Heart rate decrease. ACE inhibitors don't really affect heart rate. A respiratory rate increase, they don't really affect respiratory rate either. Number 5. A nurse is assessing clients on a med-surg unit. Which adult client should the nurse identify as being the greatest risk for insensible water loss? Remember that insensible water loss is that water loss that you have that you can't really have any control over, like breathing, sweating, things like that, okay, through your skin, through your lungs. So which one of these has to deal with breathing through your skin or your lungs? Is it furosemide? Okay, that's lost through the kidneys. Tachypnea, that's lost through the lungs. Fluid restriction, they're not going to have a loss. And constipation, they're not going to have a loss. So you're left with A or B, okay? A is a medication-controlled water loss, and then B is an insensible water loss, okay? So if you have somebody who's anxious and breathing really fast, they're losing water through the water vapor that they're breathing out of their lungs. Okay, so I went ahead and brought up the questions. I thought that'd be better than looking at a screen that I'm not doing anything with. So let's look at number 6 here. A nurse is evaluating a client who is being treated for dehydration. Which assessment result would the nurse correlate with the therapeutic response to the treatment plan? That is another really wordy question. So let's figure out what the heck it's asking us. So we have a patient being treated for dehydration. Okay? Therapeutic response to treatment. That means which patient is no longer showing signs and symptoms of dehydration, or a patient that's symptoms are getting better. Okay, so we need to find somebody whose symptoms are getting better from dehydration. So, first of all, let's look at respiratory rate. Remember what I said about respiratory rate in dehydrated patients. Their respiratory rate goes up when they're dehydrated. So if you have somebody that you're treating for dehydration, you would expect their respiratory rate to be coming down. Okay, so A, incorrect. B, decreased skin turgor. Now, if you have somebody who is recovering from dehydration, their skin turgor should be improving. Okay? Increased urine specific gravity. Remember what I said about specific gravity. The more concentrated your urine, the more higher your specific gravity, right? So you would expect that when you're recovering from dehydration, your urine's going to become less concentrated. So you're going to have a decreased urine-specific gravity. And then we have decreased orthostatic lightheadedness and dizziness. So if you have somebody who's dehydrated, they're going to be dizzy, they're going to be orthostatic, okay? And if you treat them and their fluid volume is becoming back to equalized again, those symptoms are going to go away. So the answer is D. Let's look at number 7. Number 7 is, let me see here. After teaching the client who is prescribed a restricted sodium diet, a nurse assesses the client's understanding. Which food choice for lunch indicates the client correctly understood the teaching? So which one of these diet choices is the correct one for a patient who's on a low salt diet? So which one of these diet choices is low salt? A. Slices of smoked ham. Ham, salt. B. Tomato soup and grilled cheese. Soup, cheese, salt. C. Salami and cheese on whole wheat crackers. I know the whole wheat, oh, that's healthy. No. Salami, cheese, salt. Grilled chicken breast and glazed carrots. That's the answer, D. 8. A nurse assessing clients for fluid and electrolyte imbalances. Which client should the nurse assess first for potential hyponatremia? So what is this question asking us? Which one of the following clients is at risk for hyponatremia? Okay. If you look at these answers, we have a 34-year-old with NPO status. We have a 50-year-old with an infection. We have a 67-year-old who's experiencing pain. And we have a 73-year-old with tachycardia. Okay, so of all of these, which of these directly deals with fluid and hydration status? The first one, correct? So somebody who's NPO, they're already at risk for an electrolyte imbalance because they're not taking anything in, okay? Then we have, let's look at number 9. A nurse teaches a client who is at risk for mild hypernatremia, high salt, okay? Which statement should the nurse include in the client's teaching? So what's this question asking? What are you going to teach somebody who's at risk for mild hypernatremia? Okay? So if you have somebody who's at risk for mild hypernatremia, what are you going to teach them about? You're going to teach them about weighing themselves? Weighing, even though salt and water go together, weighing yourself tells you more about fluid than it does about salt, because the fluid could be from something else, not salt. So it's not a really good indicator about salt. Checking your pulse twice a day doesn't really have anything to do with hypernatremia. Reading food labels for sodium content, absolutely that one, because you don't want them to eat too much salt. And then bake or grill the meat rather than frying, that has more to do with fat than salt. So the answer would be C, reading the food labels. Number 10, a nurse caring for a client who has the following lab values. Potassium's 3.4, mags 1.8, calcium 8.5, sodium 144. Which assessment should the nurse complete first? Okay, so which one is the most important? Well, let's look at our lab values. The only one that's truly low is going to be your potassium, right? So then which one of these assessments do we need to complete first? Meaning, out of these, which ones are complications of hypokalemia? And number 2, out of those, which one is the most life-threatening? Okay? So, let's see here. We have depth of respirations. That can be affected by hypokalemia. Remember, we said it affects the diaphragm. 2, bowel sounds. Yes, we said potassium also affects bowel sounds bowels if you have hypokalemia. You can have paralytic ileus and things like that. Number 3, grip strength. Yes, potassium can cause muscle weakness, low potassium. And D, EKG problems. Yes, potassium can cause problems with your EKG. Now, all of them then can be signs and symptoms have to do with low potassium. So now we have to choose which one is a priority, because remember it says complete first. Which one's a priority? A, B, C, safety. Okay, so A is the correct answer because that is breathing. Okay, and you say, well, what about, cardiac and heart, low potassium heart? Yes, but A, B, C. Cardiac comes after breathing, okay? So respirations come first because it can affect the diaphragm. Number 11, a nurse cares for a client whose potassium is 7.5. So here we have hyperkalemia, and they're starting to have cardiovascular changes. Which prescription should the nurse give first. Okay, so we've got a high potassium and the patient is starting to show signs and symptoms of the high potassium, including cardiovascular changes, which we know in hyperkalemia can be life-threatening. So which one of these do we want to do first? Okay, so we've got the K-oxalate, which remember the K-oxalate's the one where they take it in by mouth and it pulls the potassium out through the stool. Low potassium diet, so that's just going to prevent any more from coming in. We've got the dextrose and the insulin. Remember the insulin and the glucose train? And then we have hemodialysis. Which one of these is going to work the fastest? Okay, so let's narrow this down. We know it's not the low potassium diet because that's not getting rid of potassium, that's just preventing any more from coming in. And then we have the K-oxalate by mouth. PO does not work as fast as these other two. Okay, so now we've got the IV insulin and we have the hemodialysis. Do they both work quickly? They can, but here's the thing with hemodialysis. If the patient doesn't already have hemodialysis access, they still have to get a line in to do the hemodialysis, and then it takes hours, where the insulin and dextrose will work quickly, within minutes. Okay, so the answer is going to be the insulin. Okay, number 12, a nurse is assessing clients on a med-surg unit. Which one's at risk for hypokalemia? Okay, so this one's pretty straightforward. Which of the following patients is at risk for hypokalemia? A client with pancreatitis who has NG suctioning. Okay, a client who is prescribed ACE inhibitor. A client with a motor vehicle accident who had packed red blood cells. Or a client with uncontrolled diabetes with a pH of 7.33. So which one is at risk for hypokalemia? Okay, first of all, let's look at NG suctioning. Does NG suction out, does an NG tube or vomiting get rid of your potassium? Yes, it does. So that one is, yes, that one's hypokalemia. But let's just look at the others. ACE inhibitor works on your sodium, doesn't really work on the potassium too much. Motor vehicle crash who is receiving 6 units of packed red cells, no, that's probably not going to affect your potassium too awful much because they've lost a lot of blood, so they're just going to replace the blood. And then you have uncontrolled diabetes with a pH level of 7.33. Now that patient is becoming acidotic, probably diabetic ketoacidosis. This patient, remember what I told you about potassium and acidosis and alkalosis. High acid, high potassium, low acid, low potassium. So this patient is becoming acidotic or high acid, so they're going to have a high potassium. Okay? So what's the correct answer then is A, continuous NG suctioning. 13. A nurse assessing a client with hypokalemia notices the client's hand grip strength has diminished since the previous assessment 1 hour ago. What action should the nurse take first? Remember, airway, breathing, circulation. Okay? So let's look at the answers. If we do airway, breathing, circulation, safety, number 1, assess respiratory rate, rhythm, and depth. There you go. That's probably your answer, but let's look at the rest of them. Measure the client's pulse and blood pressure. That's circulation. That comes after the airway, breathing. Document the findings and monitor the client. No, if they're starting to show symptoms of hypokalemia, remember we're worried about cardiovascular and respiratory with hypokalemia because it can depress the cardiac system and it can also depress the respiratory. And then call the healthcare provider. I guarantee you if they call the doctor and you tell him that the patient's having diminished hand grip strength, he's going to ask you about the respiratory. So you're going to assess respiratory, A, B, C, safety. Okay, let's look at number 14 here. Let me scroll up here a little bit. After teaching a client to increase dietary potassium intake, a nurse assesses the client's understanding. Which diet meal selection indicates that the client correctly understands the teaching? So which one of these is going to be, meals is going to be high in potassium? Okay? And the correct answer is C. Sausage, toast, raisins, and milk. That's high in potassium. 15. A client at risk for developing hyperkalemia says, I love fruit and I usually eat it every day, but now I can't because of my high potassium level. How should the nurse respond? Okay, so what the question's asking you is he right? Can he not eat any more fruit because he has high potassium? So let's go through the answers. Potatoes and avocados can be substituted for fruit. B, if you cook the fruit, the amount of potassium will be lower. C, berries, cherries, apples, and peaches are low in potassium. Or D, you're correct, fruit's high in potassium. So the correct answer is C, berries, cherries, apples, and peaches are low in potassium. The nurse is caring for a client who has a serum calcium of 14, okay? Which provider order should the nurse implement first? Okay, so we have somebody who is high in calcium, okay? And remember what we said about a high calcium level. It slows everything down. We can get bradycardia and blocks. So what you want to do is you want to put them on a cardiac monitor. And if you don't remember that, remember this. You've got 4 doctor's orders here. Which one should you do first? A, B, C, safety. Do we have an airway or breathing here? No, we don't. Do we have a circulatory or cardiac? Yes, we do. We've got B, connect to the cardiac monitor. That is the correct answer. 17. A nurse caring for an older client who's admitted with moderate dehydration. Which intervention should the nurse implement to prevent injury while in the hospital? Okay, so we have somebody who's dehydrated and we want to prevent them from injury. How are they going to injure themselves? They're most likely at a fall risk because of dizziness and lightheadedness. So let's see what the answer is here. Ask the family member to speak quietly and calmly. Okay, well, they're not really at risk for agitation when they're dehydrated. Assess urine color, amount, and specific gravity each day. That's true, but that's not really preventing injury. Encourage the client to drink at least 1 liter of fluid each shift. Yeah, but again, that's not really preventing injury. Okay? Dangle the client on the bedside before ambulating. Yes, because that will diminish the risk for orthostatic hypotension, which if you have low fluid volume, you're going to be more likely to be orthostatic when you stand up because your body's going to have a hard time adjusting to the lower fluid volume against gravity. Okay, so dangling the feet at the side of the bed will give the body time to adjust before you stand up. That is the correct answer. 18. The nurse assesses a client who's admitted for treatment of fluid overload. Which manifestations should the nurse expect to find? So what's the question asking? Which are the following signs and symptoms of fluid volume overload? Okay. Increased pulse rate. That is going to be correct. You're going to have an increased pulse rate with fluid volume overload and dehydration, but for different reasons. Okay, so you're going to have an increased pulse rate with fluid volume overload because of hemodilution. So your body sees that you have high fluid, but you have low red blood cells and oxygen concentration in there because of the proportion for fluid to particles, right? So you have hemodilution. So your body sees that and it ups the pulse rate so that your body can pump out the oxygen faster. Distended neck veins. Yes, because fluid volume overload backs up in the venous system and you can get distended neck veins. Decreased blood pressure? No, you're going to have an increased blood pressure because blood pressure is affected by what 2 things? Volume and constriction of blood vessels. Warm and pink skin? No, not with fluid volume overload. And skeletal muscle weakness? Yes, you can have skeletal muscle weakness because remember, one of the problems with fluid volume overload is you get hemodilution, which then will drop your electrolytes. And that can cause your sodium and potassium to drop, which will cause muscle weakness. Let's look at number 19. The nurse is assessing clients on a med-surg unit. Which clients are at risk for low phosphorus? Okay, so let's see. Which ones are at risk for low phosphorus? 36-year-old malnourishment? Yeah, malnourished or not getting they're not getting the nutrition intake they should. Uncontrolled diabetes. Okay, so if you have uncontrolled diabetes, you're going to get some fluid shift going on inside your body, and that can cause your phosphorus to drop. And then you have a 76-year-old who is prescribed antacids. That one is also correct because the antacids are going to raise your calcium. And remember, calcium, phosphorus, the little teeter-totter. When the calcium goes up, the phos goes down. Okay, let's look at number 20. A nurse is caring for clients with electrolyte imbalance on a med-surg unit. Which clinical manifestations are correctly paired with the contributing electrolyte imbalance? So it's basically saying which of these are correct. Okay? Low potassium. Does it cause paralysis and respiratory depression? Yes, we've talked about that. Low phosphorus. Does it cause paresthesia with sensations of tingling and numbness? No. Hyponatremia. Decreased level of consciousness. Yes, remember we said sodium, neuro. Hypercalcemia. Positive Trousseau's and Chopsticks. Trousseau's and Chopsticks are a hyperexcitability, okay? Overexcitability. Those happen in a low calcium because remember the low calcium allows the sodium to come in. The sodium causes the overexcitability. So that one is incorrect. A high calcium causes a slow down effect. The low calcium causes the hyperexcitability. So that one's incorrect. Hypomagnesemia, bradycardia, peripheral vasodilation, and hypotension. No. High mag is going to cause the slowing down, not a low mag. Remember, magnesium and calcium are the opposite of potassium and sodium when it comes to membrane excitability. And then we have, after administering 40 MEQs of potassium chloride, a nurse evaluates a client's response. Which manifestations indicate that treatment is improving the client's hypokalemia? Okay, so again, this is one of those things that's saying which of the signs and symptoms are telling us that their low potassium is improving, okay? Respiratory rate of 8. No. That would mean the potassium level is getting lower. Remember, because low potassium slows down everything. Absent deep tendon reflexes. Again, no, that would mean the potassium is getting lower because the low potassium means slowing things down. Strong productive cough. Yes, that means that their potassium level is coming back to normal and their muscles are communicating with their nerves correctly, and we cough nice, big, and strong. Active bowel sounds. Yes, remember, hypokalemia causes things like constipation and paralytic ileus. When we have active, nice bowel sounds, that means the potassium level is coming back up and everything's communicating. U waves present on EKG. No, that is when the potassium is getting lower. Okay, so your answers are the strong productive cough and the active bowel sounds. Okay, let's talk about acid-base here a little bit. Number 1, a nurse assesses a client with diabetes who is admitted with an acid-base imbalance. Okay, right away, remember we said with diabetes, your body can't get the glucose it needs, so it starts breaking down muscle and fat. When it does that, you get fatty acids which turn into ketone bodies, and the ketone bodies then create the ketoacidosis. So this patient is mostly going to be in an acidotic state. Okay, so let's take a look here. The client's ABG values are as follows. pH of 7.36. Okay, first of all, we're going to commit this to a side. Even though this pH is within range, we say that because it's less than 7.4, which is the middle marker of the normal range for pH value, it's less than that. It's less than 7.4, so it's still a little bit on the acidotic side. We have a CO2, which is 33. Okay, so it's a little bit low. Okay, so the CO2 is, there's a little bit too much of it gone. And then we have a bicarb of 18, which is also low. Okay, so we've lost the bicarb. So this is a metabolic acidosis, and then the lungs are trying to breathe off the acid to compensate. Okay? Remember we said that our body's always trying to check itself and fix itself, and when one thing goes wrong, something else tries to fix it. So that's what's happening here. We have a ketoacidosis going on, and the kidneys are blowing off their acid to try to get rid of some acid in the body to try to bring that pH back up to normal range, which it's doing. It's back in normal range, but it's still a little bit, it's leading toward the acid side. So, we have an acidosis going on here. Which manifestation should the nurse identify as an example of the client's compensation mechanism? Remember I just said, how does the body compensate for a metabolic acidosis? Your lungs get rid of the acid, okay? How do they do that? Kussmaul's respirations, guys. Increase rate and depth of respirations. So the first one is correct. Number 2, the nurse assesses a client who is experiencing an acid-base imbalance. The client's ABG values are pH of 7.34. Okay, so we know that one, 7.35 to 7.45 is normal, so that's a little acidotic. We have a CO2 of 38, so 35 to 45 is normal. That CO2 is within normal range. Okay, so we know that the CO2 is not the problem. And then we have a bicarb of 19. 22 to 28 is normal. This bicarb is low. So this is a metabolic, because we're talking about the bicarb being out of range. Acidosis, because we've got an acidotic pH. The CO2 is in range, so it's not the lungs that are causing the problem. It's something with the bicarb, some kind of metabolic problem. We have a metabolic acidosis. Which assessment should the nurse perform first? Okay, so which one of these are we going to assess first? Remember, airway, breathing, circulation, safety. Anytime it asks you for what are you going to do first or what's a priority, airway, breathing, circulation, safety. Correct answer then would be circulation, letter A. That's the only one that has the ABCs in it. Okay? Next one. The nurse assesses a client who is prescribed furosemide for hypertension. Which acid-base imbalance should the nurse assess to prevent complications of this therapy? Okay, so what's happening with this? Okay, so the answer to this question has to do with that potassium-hydrogen relationship that we talked about before. When you have a potassium-hydrogen relationship, we have a low potassium, because remember, furosemide kicks the potassium out through the kidneys. Remember, when you think furosemide, you think potassium, low potassium, okay? So we lose our potassium through the kidneys. Okay, so that means the level of potassium in our blood is low. So then the cells kick out some of the potassium into the bloodstream to level things out. When it does that, the hydrogen sees a spot in the cell that it wants to go into because the potassium's out of it now. And so the hydrogen leaves the bloodstream and goes into the cell. That means we've got lower hydrogen levels in our blood, meaning low hydrogen means low acid means alkalosis. We have a metabolic alkalosis. Why do we call it metabolic? Because the lungs were not involved at all. Okay? Okay, let's look at number 4. A nurse is caring for a client who is experiencing moderate metabolic alkalosis. Which action should the nurse take? Okay? So this one we're going to do, we're going to talk to them about preventing falls. Let's look at number 5. The nurse is assessing a client who has acute pancreatitis and is at risk for an acid-base imbalance. For which manifestation of this acid-base imbalance should the nurse first assess? Okay. This one might be a little bit tough because you guys haven't really learned that much about pancreatitis. But one thing that the pancreas do is they put bicarb into the intestines to counteract the stomach acid that comes in from the stomach into the intestines. So if the pancreas aren't able to work because they're inflamed and clogged from pancreatitis, then that bicarb doesn't get put out. And if the bicarb doesn't get put out, then the pH is going to drop. Okay, and you're going to get a metabolic acidosis situation. Okay, so if you have a metabolic acidosis, okay, nothing to do with the lungs, it's metabolic because it came from somewhere other than the lungs, and it's an acidosis because your bicarb is not working like it should. So your pH drops and you get a metabolic acidosis. How do we compensate for that? Okay, you're going to see Kussmaul's respirations because, again, your lungs are going to try to fix the problem by getting rid of the acid through the CO2. Okay, number 6, a nurse assesses a client who's admitted with an acid-base imbalance. The client's ABG are as follows: 7.32, acidotic, CO2, it's a little bit on the low side, and a bicarb of 16. Again, that bicarb's out of range to the acidotic side, and we have an acidotic pH. This is a metabolic acidosis. Okay, what action should the nurse take next? Okay, again, airway, breathing, circulation, safety. Number 1, or letter A, sorry. Assess airway, breathing, circulation. Airway, breathing first. Number 7, nurse caring for a client who has the following ABGs. 7.12, acidotic. PaO2 of 56. Guys, that's super low. Okay? Just keep that in mind. 80 to 100 is normal. CO2 of 65. Okay, 35 to 45 is normal. This guy's got lots of extra CO2 on board. And a bicarb of 22. That's in normal range. Bicarb's not doing a thing. This is a respiratory acidosis. Which clinical situation should the nurse correlate with these values? Okay, so is this a diabetic ketoacidosis in a person with emphysema? No, diabetic ketoacidosis is a metabolic acidosis. We need to find a respiratory acidosis. Bronchial obstruction related to aspiration of a hot dog. Possibly. If your airway is blocked, not only can you not get oxygen in, you can't get the CO2 out. Anxiety-induced hyperventilation. No, we said the hyperventilation, they breathe fast and they get rid of too much CO2. This patient has too much CO2 on board still. And then diarrhea for 36 hours, that has nothing to do with respiratory, that's a metabolic. And that would be, that's a metabolic, so that wouldn't have anything to do with, we're dealing with a respiratory. So the answer would be B, bronchial obstruction related to aspiration because the patient cannot get rid of the CO2. And if you looked at the PaO2, it was also low because he's not getting the oxygen in either. 8. The nurse is caring for a client who has just experienced a 90-second tonic-clonic seizure. The client's ABG is as follows: 6.88. Yikes, that's an acidosis. Okay? PaO2 of 50, again, super low oxygen level. CO2, 60. Okay, guys, this is another high CO2 level. 35 to 45 is normal. And then we have a bicarb of 22, okay, which is normal range. So we have a respiratory acidosis with a low oxygen level here. Which action should the nurse take first? Airway, breathing, circulation, safety. Okay, so what do you do first? You're going to give that patient oxygen. He's got a low oxygen and a high CO2. You've got to give him some oxygen. Are you going to put the paper bag? No, he's going to breathe in more CO2 that way. Give bicarb IV maybe later, but first you're going to give that oxygen. And then glucose and insulin, no, that has to do with the high potassium. That's not going to help you. 9. After teaching a client who was malnourished and being discharged, the nurse assesses the client's understanding. Which statement indicates the client correctly understood understood teaching to decrease the risk for the development of metabolic acidosis. Okay, so which one of these is going to decrease the risk of metabolic acidosis? Drinking 3 glasses of milk each day? It's not really going to help. Eating 3 well-balanced meals and snack daily? That one sounds pretty good, right? That's what you'd tell anybody. I will not take pain medication and antihistamines together. Not really going to make a difference. I will avoid salting my food when cooking or during meals. That doesn't make a difference either. The only answer is B. The nurse evaluates the following ABG values in a client. 7.48. Okay, so that pH is a little alkalotic. Okay, PO2 is fine. CO2 of 28. Okay, this person got rid of a lot of CO2. Okay, 35 to 45 is normal. And a bicarb of 22, which is within normal range. Which client condition should the nurse correlate with this result? So we are in a respiratory, because our CO2 is out of range to the alkalotic side, and we have an alkalotic pH. So we have a respiratory alkalosis. What do we say are the patients who are respiratory alkalosis? Anxiety and mechanical vents. So let's look for one of those. Diarrhea and vomiting, that would be a metabolic. Anxiety-induced hyperventilation, ding, 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 there's your answer. COPD, that's also a breathing one, but that is going to be the opposite. You're going to get an acidosis with that because the patient can't get rid of the CO2. And then diabetic ketoacidosis, again, even though the emphysema breathing's in there to throw you off, that would be a metabolic situation with the diabetic ketoacidosis. So no, it would be the hyperventilation. Number 11, after providing discharge teaching, the nurse assesses the client's understanding regarding increased risk for metabolic alkalosis. Which statement indicates the client needs additional teaching? So which one of these is false? Okay? I don't drink milk because it gives me gas and diarrhea. No, that's probably true. I have been taking digoxin every day for the last 15 years. That doesn't, you don't have to worry about metabolic with that. I take sodium bicarb after every meal to prevent heartburn. Bicarb, alkalosis, that sounds right. In hot weather, I sweat so much that I drink 6 glasses of water a day. No, that's okay. So taking the bicarb after meals can cause alkalosis. So we have to be careful about that. Number 12. The nurse is caring for a client who is experiencing excessive diarrhea. Okay, what did we say causes excessive diarrhea? I'm sorry, what do we say causes excessive diarrhea causes? Okay, remember pooping out your bicarb. When you have excessive diarrhea, you get into a metabolic acidosis because you poop the bicarb out. Okay, the client's arterial blood gas are as follows: pH of 7.28, acidotic, okay, O2 is normal, CO2 45, 35 to 45 is normal, CO2 is fine, bicarb of 16, so remember he's 22 to 28 is normal, losing his bicarb, okay, he's pooping it out, so this is a metabolic acidosis. Which provider order should the nurse expect to receive? Okay. We're in an acidosis, so how do we fix this? We either get rid of the acid or we put some bicarb on board, right? So, Lasix IV push. That's not really going to help the issue. Sodium bicarb. Yes, that can help. Mechanical ventilation. That's a little bit extreme. We don't want to go that far just yet. And urinary catheter, that's not going to do anything for you. Okay, so sodium bicarb is the correct answer there. Number 13. Nurse evaluates the client's ABG. 7.3, acidotic. CO2, 55. That's acidotic. And a bicarb of 22, that's normal. So this is a respiratory because it's acidotic. It's on the high on the acid level. And we have an acidotic pH. Respiratory acidosis. Which intervention should the nurse implement first? Airway, breathing, circulation, safety. Which one comes first? Okay. Assess the airway. Okay? The word airway is right there in your answer. That's the one you pick. Okay? Bronchodilators, does that also have to do with airway? It does. But when you think about The nursing process, you assess before you intervene. So you're going to assess the airway, then give the bronchodilators. Then breathing for oxygen, okay? And the mucolytics, you're going to do that as well. That's going to help the breathing and airway as well, but you always want to assess first. 14. The nurse is planning care for a client who is hyperventilating. The client's ABG values are as follows. Let's see. We have an pH of 7.30, which is actually a little acidotic. We have a CO2 of 31, and we have a bicarb of 26. So which questions should the nurse ask when developing the patient's plan of care? Actually, I think this is a typo, because if the person, let's critically think this out. If the person's hyperventilating, they're blowing off their CO2, and if you look at the CO2 level there, it is low. Okay, the bicarb's normal, your oxygen's fine, so that CO2 is low. So this pH should be high. This pH is low. So this, I think what they meant to say is like maybe 7.50. I'm not sure. But this should be a respiratory alkalosis. Hyperventilating patients do a respiratory alkalosis. So let's go with that. Okay? So which one of these, when we're developing the plan of care, should we talk to the patient about? What do we want to explore? Do you take any over-the-counter meds? So does over-the-counter meds really affect your respiratory alkalosis? No. You appear anxious. What is causing your distress? That may help, but let's keep going. Do you have a history of anxiety attacks? Yes. When you're developing the patient's plan of care, you want to know if they're having a history of anxiety attacks, because this may happen to them again at home. And you are breathing fast. Is this causing you to feel lightheaded? Well, if you're treating the patient, yes, but right now we're developing their plan of care, so that's not really what we're worried about. We hopefully have already treated that issue. So it's going to be between B and C. You appear anxious, what's causing your distress? And C, do you have a history of anxiety attacks? Well, when you're planning their plan of care at home, you want to find out if they have a history of anxiety attacks at home, because this could happen to them at home again. So you're looking more long-term. Number 15, the nurse is caring for a client with chronic emphysema. He's on O2 at 6 liters. Here's the following data. 7.28, so he's acidotic. O2 is normal. CO2 55, 35 to 45 is normal. Okay, so he's holding on to that CO2. Bicarb's normal. Pulse is good. Blood pressure is good. Respiratory rate, 6 breaths per minute, so he's not breathing very fast, which is why he's holding on to the CO2. O2 sat 88%, because he's not breathing very fast. Which action should the nurse take first? Airway, breathing, circulation. Okay, so notify the rapid response team and provide ventilation support. This patient's only breathing 6 per minute. Hold on to that CO2. That's a possibility. Let's look at the other answers. Change the nasal cannula to a mask and reassess in 10 minutes. Oxygen's not really his problem. Look at his PaO2. That's not his problem. Okay? He's got an okay oxygen level. Place the client in Fowler's position if he or she is able to tolerate it. Positioning isn't really going to help. The respiratory rate is the problem, so we have to fix that rate. Decrease the flow rate of oxygen to 2 to 4 and reassess. That's possible, but what we need to do is, he's beyond now, so the correct answer is to provide ventilation support. So we're going to notify rapid response and provide ventilation support. Although with this question, it's possible, I would actually maybe even argue that question, because if you have somebody who has emphysema and you have them on 6 liters, and you're going to decrease their respiratory drive. That's going to drop their respiratory rate, and it's going to make them retain the CO2. So it's very possible that if you decrease that oxygen, he might come back to normal. But for the sake of the question, it's telling you need to provide ventilation support for this guy. And number 16, the nurse is planning interventions that regulate acid-base to ensure the pH of a client's blood remains normal. Okay, which abnormal physiologic functions may occur if the client experiences an acid-base imbalance? So basically these saying are, what are the following are signs and symptoms of acid-base imbalance? Reduction in the function of hormones. The hormones need to have that pH within a certain level for them to work right. So if that pH is out of range, the hormones aren't going to work right. Fluid and electrolytes, again, remember we said the potassium and the hydrogen relationship there. Excitable cardiac muscle membranes. I guess if you have a pH imbalance, if you have the potassiums out of range, then yeah, you can have excitable cardiac muscle. An increase in the effectiveness of many drugs. Yes, if that pH is out of range, the drugs can become less effective or more effective. Number 17, the nurse, let me pull this down here. The nurse assesses a client who is experiencing an acid-base imbalance. The client's arterial blood gas is 7.32, acidotic. CO2, 34, that's a little bit on the acidotic side, alkalotic side. And the bicarb is 18, that's acidotic. So the bicarb matches up. Bicarb is a little toward the acidotic side, and the pH is the acidotic side. So we have a metabolic acidosis. Which clinical manifestations should the nurse assess for? So when we have a metabolic acidosis, you're going to have decreased deep tendon reflexes, you're going to have drowsiness, and you're going to have an increased respiratory rate because your lungs are going to be then trying to compensate. Number 18, the nurse is assessing clients who are at risk for acid-base imbalance. Which clients are correctly paired with the acid-base imbalance? Okay, so metabolic alkalosis, a young adult who is prescribed IV morphine for pain. So if he's got IV morphine, it's going to decrease the respiratory drive. You're going to hold on to the CO2. You're going to have a respiratory acidosis. That is incorrect. B, metabolic acidosis, older adult who is following a carbohydrate-free diet. So this guy is probably, if he's on a carbohydrate-free diet, then he's probably got a little bit high glucose level in the blood, which if you have hyperglycemia, that means it's not getting into the cells, which means that the cells are going to break down other things, which leads to metabolic acidosis. That is correct. Respiratory alkalosis, client on a mechanical vent at a rate of 28 breaths per minute, breathing off too much CO2, respiratory alkalosis. Next one, respiratory acidosis, post-op client who received 6 units of packed red cells. No, the 6 units of packed cells isn't really going to have anything to do with him holding on to CO2. So that one's incorrect. And metabolic alkalosis, older client prescribed antacid for GERD. Yes, they can develop metabolic alkalosis if they take too many of them. And last but not least, we have a nurse planning care for a client who is anxious and irritable. The client's ABG values are a pH of 7.3, which is acidotic, a PaO2 of 96, that's normal, CO2 of 43, 35 to 45 is normal, that's a normal one. A bicarb of 19, that's acidotic, the pH is acidotic, we have a metabolic acidosis. Which question should the nurse ask the client and spouse in developing a plan of care? So you have somebody who is anxious, irritable, metabolic acidosis. What do we want to ask the client? Are you taking any antacids? No, antacids would cause alkalosis. We're not worried about that. Is your spouse's current behavior typical? So why are they asking that? They're asking that to see if he acts like this a lot, he might be getting acidotic at home. Okay, so we need to try to fix this situation. Do you currently drink any alcoholic beverages? Alcohol can cause the metabolic acidosis as well. Have you been experiencing any vomiting? Vomiting is going to cause an alkalosis, so that's not the problem. Are you experiencing any shortness of breath? Shortness of breath again is going to cause respiratory acidosis, so that's not the problem. Okay, so your answer is going to be 1 and 2, or A and B rather. Oh wait, I'm sorry. B and C. Okay, well that concludes the fluid and electrolyte acid base. I know this one was lengthy, but there's a lot of material to cover, so hope this helps you guys out. If you have any questions, you can email me or you can ask Ms. Coughlin. Thank you very much. Good luck on your test.